Hello, my name is Elias Mai from Heidelberg University Hospital. I work in the multiple myeloma space as a physician for almost 12 years now, and I treat mostly newly diagnosed patients with multiple myeloma, with relapse refractory multiple myeloma, as well as patients with precursor diseases such as smoldering multiple myeloma. When I started almost 12 years ago in the space, we really had only a few opportunities for our patients, and we didn't have much options once the patients had a relapse disease. And since that, the space really evolved a lot. So we see a lot of new immunotherapies coming in every year. And of course, the monoclonal antibodies like Isatuximab or daratumumab moved into the first line, but we also see that the bispecific and the CAR T cells are moving into earlier lines, which is magnificent for our patients. So GMMG-HD7 is a multi-center randomized phase 3 trial that included 662 patients. And the trial has two parts and two independent primary endpoints. So in the current abstract, we report the progression-free survival from the first part of the trial. In the first part of the trial, patients were randomized 1-to-1 to receive an induction therapy with either Isatuximab, lenalidomide, bortezomib, and dexamethasone, or lenalidomide, bortezomib, and dexamethasone alone. Thereafter, all patients proceeded to high-dose melphalan and autologous blood stem cell transplantation. And if patients achieved less than a complete response or had a high-risk disease, they could even opt for a tandem transplant. Thereafter, the second part of the trial began, and in this part, patients were again randomized 1-to-1 to receive either lenalidomide, the current standard of care as maintenance therapy, or isatuximab plus lenalidomide for up to 3 years. And as I mentioned, we have two parts in the trial. So we have two independent primary endpoints. And the first primary endpoint of the study was MRD negativity rate post-induction and has already been reported in 2022. The second primary endpoint is progression-free survival from the second randomization, which will be reported when data are mature. At the current data cutoff, we have a median of 48-month follow-up from the first randomization, and we could see that the progression-free survival is significantly longer in patients that received Isatuximab RVd induction as compared to patients who received RVd induction alone. And this was a 30% reduction in the risk of progression or death. Notably, this was regardless of the fact that the patients were randomized again to maintenance therapy and the fact that more patients received a second transplant in the RVd arm. The first thing we saw is that the MRD negativity rates post-transplantation continued to deepen. So in the patients that were treated with either RVd induction, MRD negativity rates were almost 70% post-transplant as compared to 48% in the patients that were treated with RVd alone. And then we went on with this follow-up of a median of 48 months now from the first randomization, and we saw that the addition of Isatuximab to RVd induction resulted in a 30% risk reduction for progression or death as compared to RVd alone. And we also conducted sensitivity analysis where we waited for the second randomization and we could confirm the results. We further looked into predefined or pre-specified clinically relevant subgroups, and we saw that most of these subgroups of patients had a benefit from the addition of Isatuximab to RVd during induction therapy. We then went on and even made a multivariable model. And in this multivariable model, where we included known adverse prognostic factors such as a high international stage system, stage 3, or adverse cytogenetics, we could still see that there was a significant benefit from the addition of Isatuximab to RVd during induction therapy. Quadruplet induction therapy with an anti-CD38 monoclonal antibody plus lenalidomide plus bortezomib plus dexamethasone is a current standard of care and should be used in all patients with transplant-eligible newly diagnosed multiple myeloma. Our results highlight that a quadruplet induction regimen with Isa-RVd for 18 weeks leads to a significant progression-free survival benefit independent of the second randomization and also independent of the fact that there was no additional consolidation post-transplant used. So I just want to add that our study group is continuing to use this regimen frontline in patients with newly diagnosed multiple myeloma who are transplant eligible. And we have a current study ongoing, which is the GMMG-HD8 trial. So after 7+8, of course, we are happy that we can offer this excellent treatment to our patients that participate in the trial in Germany and Austria.